Do you guys have enough time to catch up with food and drinks and everything? I guess no, people are still standing. So the aim of today's talk is to provide an overview of movement disorders and review some nomenclature used to describe movement disorders the way we talk about them, so that when you're in the emergency room and you call me and you page me, or you page Gene, Hugh, or Mike, you can describe exactly what you're seeing. So I'll briefly go over treatment options and also some videos in between some of these various movement disorder types. So the key thing is close observation with attention to a few important points on history and examination. So pay attention to the distribution of body parts, pay attention to the speed of movement, whether it's fast or whether it's slow. Pay attention to whether it's rhythmic or not. Like tremor is really the only rhythmic movement disorder we have. Pay attention to whether it's present with posture or action. Remember that action tremor is present with essential tremor and resting tremor with Parkinson's disease. Most movement disorders go away during sleep, and we don't have very many that persist during sleep. And most of the time, myoclonus and restless legs are the ones that persist during sleep. So pay attention to suppressibility by volition or distraction, because they would point towards Tourette syndrome, tic disorder, or psychogenic movement disorders. Always ask about aggravating and alleviating factors. As you know, caffeine makes your essential tremor worse. Alcohol makes the essential tremor a little bit better. So ask about those things, because they may help you in differentiating essential tremor from Parkinson's type tremor. So drug exposure is very important. As you know, neuroleptics can cause tardive dyskinesia, they can cause acute dystonic reactions, and so on. So always do ask about family history when it comes to essential tremor, and Huntington's disease, and social history as well. So because you need that for psychogenicity, you need that for social stresses that are bringing on tic disorder and psychogenic movement disorders. So those are all important questions to ask. So tremor is basically an oscillation of a body part by alternating or synchronous co-contractions of agonist and antagonist muscles. So if your hand is shaking, you're co-contracting your wrist flexors and wrist extensors at the wrist, and that's what makes your hands and fingers shake. So that's sort of a definition of, sort of a basic definition of tremor. So the tremor frequency should really not change from one moment in time to another moment in time unless it's psychogenic. And most of the time it changes less than 1 hertz from one epoch in time to another. And when you're having very fast enhanced physiologic tremor or essential tremor, is probably due to synchronous co-contraction of these muscles. But when you're having sort of alternating contraction of these muscles, is probably the kind you see in resting tremor, Parkinson's disease. So resting tremor is a very tricky thing. So you may think that somebody has resting tremor, but really their hand has to be resting on their lap nice and relaxed before you can commit yourself to saying that it's resting tremor. So we get a lot of consults about Parkinson's disease and resting tremor. When they come to clinic, it's really action tremor and postural tremor. So action tremor is basically either postural tremor or intention tremor or task-specific tremor. So postural tremor is when you have your hands out in front of you in a sustained fashion, or when your head is shaking, when you have head tremor. So if you're sitting down, your neck muscles are supporting your head. So that would be a postural tremor. So you don't want to call a head tremor a resting tremor when you're seated. It's only a resting tremor if you're laying down with gravity basically overcome with a head on the pillow. Intention tremor is this trajectory tremor that you see with a finger to nose test, and task-specific tremor is mostly seen during the task of writing in most people. So, and pay attention to tremor location, because you want to describe where the tremor is seen. In Parkinson's, you frequently see the pill rolling type of tremor in usually one hand. It begins asymmetrically and it goes on to the other side. You almost always have some rigidity and some bradykinesia to go along with it. So pay attention to the frequency of the tremor and whether it is present during posture, intention, or task when you describe. So here's a video of a lady with essential tremor. Very, very brief. And
mouth in the outstretched position. Hold the head.
So this is a gentleman who actually helped us write his own case report. He's an attorney. So Melanie Walker and I wrote him. He has vitamin E deficiency because he had Crohn's disease, and he had the intestinal removal down to about 2 feet of small intestine when he was a teenager. And then he had this severe malabsorption syndrome, and then he ended up getting vitamin E deficiency and ataxia and this terrible outflow tremor. So he has a wing beating component. I just want to show you what the wing beating tremor looks like. You guys saw the wing beating component of the tremor. So that's called the wing beating tremor. So in addition to the sort of intention tremor, he has a little dysmetria, which is sort of a more of a higher amplitude movement when he reaches from his nose to my finger. He also has peripheral neuropathy, which makes his tremor worse. So he's a little dysmetric and I guess dysdiadokinetic. A bit worse on the left side. And he's quite wobbly on his feet when he tries to do the finger to nose, when he tries to do the tandem gait. So this is a woman. Yes.
So are you saying that all that tremor was due to cerebellar disease then?
Probably not. Probably not. I mean,
Repeat the question.
Yes. So the question is all the tremor due to cerebellar disease? You know, he has. In fact, you did one of his nerve conduction studies, and Eric Ewan did one of his nerve conduction studies before he left us, like 12, 13 years ago. And you did one many years later, and he has severe neuropathy. So neuropathy by itself can give you an action tremor. In fact, there is a syndrome called neuropathic tremor. Usually you get that with demyelinating neuropathy in the setting of demyelination, but so that probably exacerbates his tremor. And he might also have other stuff going on. He had some borderline B12 deficiency as well. So, but he does have some cerebellar shrinkage on his MRI. It's very subtle, and he has some neuropathy. I cannot see the cursor. There you go. So this is a lady who had kidney transplant, and she had she had polycystic kidneys. She was on immunosuppressive therapy, so she had this tremor exacerbated by she was on tacrolimus, she was on steroids, she was on cyclosporin, which are notorious for giving you tremor. So you can see her hemodialysis shunt in her right arm. I don't know if you can see it. So she has a very high amplitude, either essential tremor or enhanced physiologic tremor. It's a little bit worse on the right side, her dominant side. So, and this is a sort of a textbook classic. If you really want to do a complete tremor examination, you want to have them do it in various directions and various angles. And so this is the finger to nose test. Now you can see her shunt in the right arm. That's the hemodialysis shunt. This she didn't use that at that time because she was She was after kidney transplant. So we ended up doing deep brain stimulation surgery on her, just on one side. But the unilateral tremor made the right hand tremor better. It also made the tongue tremor better.
Pick up a pen and draw a spiral for me. Let's see.
So spiral drawing is a very important thing when you do a tremor exam. So one of the things that brings out tremor more is to have the patient draw a spiral within a spiral. If you have them draw a spiral just sort of on their own, it brings out the tremor less. If you really want to bring out the tremor, in her case you don't need to, because you can actually hear the tremor because she's drawing on terrible paper.
Okay, great. Stop right there. I'm going to have you do something for me. I'm going to have you
so see if you can
start here in the middle and end here, going in between the lines like this without touching them, all the way out to this, between those 2 points.
Ideally, you also want the wrist to not rest on top of the table in which she's drawing, so that you bring out the tremor. She's resting maybe a little bit, but if you do that, if you give them a big spiral to draw, and if you tell them not to put their wrist on the table, it enhances the bringing out of the hand tremor when you're examining them. So that's another. And then we have them pour water from one cup to another, and you kind of measure the amount of spillage there is based on the amount of water there is in the cup. So I say, you know, there's a lot of spillage left to right and right to left pouring, even when the cup is only 1/4 full. That gives you an idea of how bad the tremor is. And you don't want them to rest the cup on top of the other one when you do the pouring test, because resting it dampens the tremor. So I might go on to the next person. So this is a young man. He actually had intractable epilepsy. He actually ended up having a temporal lobectomy at Georgetown University in Washington, D.C. But he had attention deficit disorder. He was put on a stimulant, Stratera, I think. And then a few months after that, ended up getting this tremor in his palate. That's palatal tremor.
And move it left and right at about 2 per second.
So I'm doing that just to make sure that that moving the tongue doesn't really upset the movement of the palate, and it doesn't. The palatal movement keeps going on, which is actually quite good. So we've talked about this, and I think that Brooke Gurton has actually given a full talk on this patient and talked about palatal tremor and palatal myotones. So I'm going to say a few words about treatment. I'm not going to dwell on treatment too much. Propranolol, primidone, and topiramate are the drugs we use for treatment of tremor, essential tremor. Benzodiazepines we also use, and we do use botulinum toxin, Botox, Dysport, Xeomin are the 3 that we now use for the dystonic component of the tremor, if there is a dystonic component to it. You can actually have tremor superimposed on dystonia, and sometimes for severe head dominant tremor, Katharine Hepburn type of tremor, you actually get a dystonia in the neck. These folks try to dampen the tremor. I'm not sure exactly why, but they go on to get dystonia, and then if you inject them, I tend to inject them fairly symmetrically. They tend to do better on top of being on these drugs. I'm going to hopefully give a talk just on Parkinson's disease at some point, so I won't even talk about these, but suffice it to say that we use these class of drugs for Parkinson's disease, mostly dopaminergic therapy or dopamine enhancers of various kinds for Parkinson's disease. So the tremor treatment for Parkinson's is the same as just treating Parkinson's disease itself. So any questions on tremor before I go on to dystonia? Okay. So dystonia is an abnormal sustained muscle contraction, usually causing twisting and turning of one or more multiple joints, with sometimes tremor superimposed on top of it. So depending on where the dystonia is it has different names. So cervical dystonia, torticollis in the neck, blepharospasm is in the eyelids, spasmodic dysphonia is in the vocal cords, rhizus sardonicus is this fixed smile dystonia. You can have jaw opening or closing dystonia. Writer's cramp is the most common type of focal limb dystonia. Segmental dystonia is when the entire limb or trunk is involved. Folks at Harborview Children's in VA can't see me, but let's say if your arm is twisted and, like, you know, rotating your shoulder inwards and pronating your wrist, and your arm is crooked with ulnar deviation and finger flexion, that would be like a segmental dystonia. Or if your trunk is involved with a lot of paraspinal muscle contraction causing twisting and turning and severe scoliotic posturing, that would be sort of segmental dystonia involving the paraspinal muscles. And then generalized dystonia, when it's sort of multifocal, involving usually one limb, the neck, the trunk, and maybe even the face. So Meige syndrome, which I omitted from this, is basically cranial cervical dystonia. So Meige is M-E-I-G. Henri Meige was a French physician who described it, which is basically a combination of cervical dystonia, blepharospasm, and cranial facial involvement. So I'll show you a video of that. So here's a lady who I've showed this video to a number of colleagues, and it's split as to whether it's psychogenic or not, but she's got dystonic posturing. The point I'm trying to get is just what dystonia would look like, whether it's psychogenic or not. And this lady, I'm not sure. She was lifting, she works as a package handler in Olympia. She used to work as a package handler in Olympia. And one day she was lifting a heavy object. It's something that was heavier than she thought. So she pulled the muscle in her forearm. And then it kind of became tight, and she kind of tried to shake it off. It just wouldn't go away. So it just kind of stayed with her. And over a few weeks to months, ended up looking like this. So right now the dystonia went away all of a sudden when she was pulling the chair, but it comes back when she tries to type. So that's why this was sort of thought to be maybe psychogenic. One of the things that happened is I had to send this video to the LNI folks and her attorney, and then they were going to sort of subpoena me to give testimony and, you know, all kinds of other things, and then the lawyers came in. So about a year after I saw her, she was getting injections by this neurologist in Olympia in her forearm, which was helping her. A year later, I got this 17-minute DVD from an attorney from a sort of a private investigation firm that had videotaped her, unbeknownst to her, after the day after her daughter's wedding, lifting stuff, and telling me this was sort of videotape on her showing she can do a lot of work. But when I looked at the videotape very carefully, she still had that abnormal flexion of the wrist and ulnar deviation at the wrist. When she was lifting stuff, she was kind of, her hand was crooked, and as soon as, you know, she was let the package go in the back of a pickup truck, she would walk back to the house, her hand was still like that. Unbeknownst to anybody, she was being videotaped from a car with a fancy paparazzi camera, many, you know, tens of yards or maybe a couple of 100 yards away. So I didn't change my testimony, but anyways. But she has that kind of a funny choreoathetotic on top of the dystonia posturing, and she has responded to Botox. I haven't seen her in a while, so that's her. This is a very brief video of Meige syndrome. This is what Meige syndrome looks like when you see somebody. Sorry, there. This is like 3 seconds or 2 seconds, so pay attention. Oh, it was shorter than that. Here we go. There you go. So she's got very forceful. Eyelid closure. She's got dystonia in her neck muscles. You can see those neck muscles, her platysmal muscles contracting. That's, I think, what Meige syndrome would look like, described by Henri Meige about 100 years ago. This is a kid that I haven't seen in a long time, but her grandmother brought him in. She watched a documentary on dystonia and then decided that this is what her grandson has. So he was sliding into third base when he was 13 or 14 years old and injured his ankle, and then started walking funny, abnormally, with a dystonic gait, and then the dystonia started to move elsewhere over the ensuing few years. Again, the idea of this being psychogenic has come up as to whether this is, you know, this idea of psychogenicity in this dystonia is a very hot topic, especially post-traumatic ones, because of LNI cases and injury cases, and we get called upon them. So this looks like a psychogenic gait, but this is very consistent, visit after visit after visit, and it happened many years before, after he had his ankle and knee injury when he was sliding into third base. So, and you saw his writing. That's the same kid writing, actually. He had a writer's cramp when he was trying to write. So, again, I'm not dwelling into the etiology. I'm just trying to show what sort of dystonia would look like when you see it, so you recognize it. As to whether it's psychogenic or not, I personally cannot figure that out in many patients, and it's just a lot of guesswork. So this is a gentleman at the Veterans Hospital who I saw. He also has this, you know, cranial cervical dystonia with blepharospasm and mostly anterocollis. He was mowing the lawn one day, and he got a piece of grass in his eye. And he kind of started going like this, and then he kind of evolved into this over several weeks to months. And he had some corneal abrasion and injury to his eye, and he thought maybe this is post-traumatic Meige syndrome. Then it started to go into his neck muscles. He started having contracting lateral neck muscles. So treating anterocollis is a very challenging and difficult thing, because you can't really inject any of the deep neck flexing muscles, which are the anterior paraspinal muscles deep in the neck. You can only inject really the sternocleidomastoid muscles and maybe the digastric down here. There's not much you can do. So these are very tough cases to treat anyways. But he's got some forceful eyelid closure with blepharospasm. So, yes. So, and here's a video I got from Phil Swanson. This is a very young woman with severe generalized dystonia. Samii, are you in the room? No? Marie, do you want to guess as to what this girl has? Genetic disease showing with dystonia as opposed to the other characteristic that we see in older people. She has actually, that was one of the things that, I don't know if it was described back then by Sagawa. She has Huntington's disease. She has the Westphal variant of Huntington's disease. That's what Phil Swanson told me when he gave me this video, which was taken decades ago. So the treatment for focal dystonia is usually botulinum toxin in the affected body part. And for people who are dystonic after having gotten, let's say, Reglan or something, you give them IV Cogentin or IV Benadryl in the ER and Artane chronically. So obviously what I said about metoclopramide is also true for Compazine and Phenergan and droperidol and other drugs which are anti-nausea drugs, which are potent dopamine antagonists, can give you dystonic reactions, so you want to treat them that way. For generalized dystonia, there's not much you can do. I mean, this is very tough. We frequently use Artane, high doses, or muscle relaxants. So when I asked Marie about what that kid could have, she said dope-responsive dystonia. That's the only really dystonia that responds very well to Cinemeds. And so that's why I listed carbidopa, levodopa here on this line. I don't have any patients with Sagawa's disease, but Dr. Swanson does. I don't know whether they are gene-documented dope-responsive dystonias or not. So we use benzodiazepines. So tetrabenazine, xenazine, has been available to treat Huntington's chorea. That's the FDA-approved label for it, but people have used it for severe generalized dystonia. As a last resort, we use intrathecal baclofen or DBS of the internal pallidum for dystonia. Any questions on dystonia before I go on to other topics? Myoclonus. So myoclonus is this sudden, brief, shock-like involuntary muscle contraction. We've had, wonderful talks on myoclonus itself, I think both by Gene Hugh as well as by Daniel Burdick in recent years with good videos. So I'm not going to dwell on it too much. They're all available on the archived lectures that we have on our website. But it's basically a positive myoclonus is this sudden, brief, shock-like involuntary muscle contraction, and negative myoclonus is a muscle inhibition of the already contracted muscle. So the other term for negative myoclonus is asterixis. You can get myoclonus from a variety of reasons, from trauma, but most common situation where we see it is after anoxic brain injury. It can be multifocal, it can be focal, it can be sort of cortical or subcortical, depending on whether you see abnormal findings when you do evoke potentials on them and so on. And it can be induced by action. So you can categorize myoclonus based on a lot of things, based on etiology, based on body part, based on whether you think it's cortical or subcortical, and all kinds of other ways of categorizing it. So here's an example of negative dystonia. This is a woman with anoxic brain injury. I think that's the etiology of it. So this is an example of asterixis.
Very good. Very good.
So she has asterixis not only in wrist extensors, but the entire what I did not show, and I clipped the video short, is that she also has knee buckling when she stands up. So another probably negative myoclonus involving her thigh muscles, probably her quadriceps giving out when she stands up. So she kind of knee buckles, so she's unable to stand by herself. So that's negative myoclonus. So, and it's very challenging to treat myoclonus. They don't respond very well to really anything. But Depakote, Keppra, and Primidone are some of the drugs we use. Phenobarbital maybe. So anticonvulsants, and then again benzodiazepines, which are by themselves, I guess, to some degree anticonvulsants we use for myoclonus. Gabapentin should probably be there too. So chorea is a Greek term. It means to dance. It's basically a series of complex, involuntary, usually purposeless movements which which resemble really extreme fidgetiness, but they're not like restless legs where they're only movement of the legs, but I'll show you videos of choreatic patients, but they're everywhere. They can involve the tongue, the face, the neck, the trunk. It's basically kind of swaying back and forth and writhing movements of the hands, and it is in a way kind of dance-like. And I think the best way to describe it is to show videos of it. So sometimes you can have dystonia superimposed on the choreatic movements. In fact, frequently you do. So in fact, when you do the UHDRS, which is our Unified Huntington's Disease Rating Scale, there's as much rating scores dedicated to dystonia as there is to chorea. So frequently they go hand in hand. Dystonia, as I said, is one of those more sustained postures. Chorea is a more fluid, faster movement. It's non-sustained. And if you were thinking of a word somewhere in between dystonia and chorea, maybe you can use athetosis. We hardly ever use that term anymore. But to me, it seems like choreathetosis would be like a slower, writhing kind of chorea. So here are some examples of Huntington's disease. Anybody want to guess as to who that gentleman is on the left side? People who haven't seen this video? Not this patient. So this patient has very mild chorea, Huntington's disease. This is a video from the 1970s. You can tell by the pants. Who is that gentleman on the left side? It's Dr. Bird. Yeah, this is Dr. Tom Bird here. And Sid Gospi has a video of me examining a child with Sydenham's chorea from 1990 when I was a resident at UC Davis and he was my attending. And he asked me, did you put that video in your chorea? And I said, no, I haven't. I have it in VHS form. I haven't digitized it yet. But he says, you should put that in your chorea collection. I said, yes, sir. So, hopefully for... So these are patients with mild chorea. Again, these are people with Huntington's disease. This is just chorea in the hands. This is a choreatic gait. They kind of sway and they have this, arm movements, and when they walk, they have this exaggerated arm swing sometimes, And their hands move and dancing in space. And that's just foot chorea. And this is a man who does not have Huntington's disease, but to me, he looks just like he has Huntington's disease. So he is in his late 40s. He became psychotic in his late 20s, and he was treated with sort of neuroleptic medications, and I think he actually got injectable some long-acting neuroleptic medications when he was in Austin, Texas, because when I got some of the reports from Texas, he had exposure to many of them. So he ended up getting chorea. He ended up getting choreatic tardive dyskinesia. Now, there are people who say there are ways to differentiate between the chorea you see in tardive dyskinesia from the chorea you see in Huntington's disease. To me, they look the same. I really can't tell the two apart. So, Eric, can you tell the two apart? They look the same to you also? Yeah. Yeah, so he has the same, I don't know if I actually have him stick out his tongue or not, but they have very similar features. They have this inability to stick out their tongue and keep their tongue out, so we call that motor impersistence. It's actually one of the parts of the UHDRS that I mentioned to you. They have trouble with squeezing your hand, so they got this milkman's grip. You see that in Sydenham's chorea children. With a milkman's grip, because they can't really squeeze your fingers continuously to provide full force. So in Huntington's disease, there might be more trouble with oculomotor disturbances early in the course of the disease. But once they have full-blown chorea, it's very hard really to tell that apart. So he also has trouble with keeping his tongue steady. So one of the ways you want to make sure that you document motor impersistence when it comes to tongue protrusion is you don't want them to seal their tongue with their teeth or their lips the way he's doing. So you want the mouth wide open with the tongue sticking right at you, not down. It's easier to keep the tongue down. So you want the tongue pointing sort of out straight, and he has trouble doing that. And you see the exact same thing in Huntington's disease. And he has two perfectly normal Huntington genes. I think 17 and 16 CAG repeats, because that was the first things we did. And then I got the records from Texas suggesting that he has. So he has not been on any neuroleptics until recently again, because he was hospitalized at Overlake for psychosis and psychotic breakdown, so he had to go back on antipsychotics. But for many years he was not on any psychotics, any neuroleptics which are dopamine antagonists, and he was still that way. He was still, very dyskinetic. Again, goes to show that a good third, maybe sometimes more, of the people who have tardive dyskinesia never go on to get better even after you stop the antipsychotics. In fact, sometimes they get worse over the ensuing months to years following the cessation of antipsychotic use. So, yes, Andrew, did you have a question, or you just knitting? Okay, sorry. So he's got chorea in his legs and he's moving around and all that stuff. For the sake of time, I should probably keep going. So we normally treat chorea by damping it with neuroleptics, with mild ones like quetiapine or more severe ones like Haldol. The more you go towards the more potent dopamine antagonists, the more likely you are to suppress the chorea, but you're also more likely to cause dystonia in some people who have chorea, so you have to monitor them. Benzodiazepines are used. We use monoamine depleters. Remember that these drugs like tetrabenazine, which has been FDA approved for Huntington's chorea, deplete not only dopamine but also norepinephrine and serotonin. That's why they cause bradykinesia, hypotension, and depression. So you have to monitor them. They deplete more than just one monoamine. So bulismus is this large amplitude, very big size chorea, which can be quite violent in nature. Usually you see it after stroke on one side in the subthalamic nucleus in people who tend to have small vessel disease. That's why we call that hemibulismus. It over time evolves into sort of less violent choreatic movements of the arm and the leg on that same side, and we would treat it normally with the same drugs that we would treat chorea with tranquilizers and neuroleptics and benzodiazepines and even tetrabenazine. Now, sometimes we see iatrogenic hemibulismus because we put electrodes in people's brains with Parkinson's disease in the subthalamic nucleus, and you get an acute lesion effect in the OR. You get hemibulismus, or if you put the electrode right where it should be and you zap at a high frequency, all of a sudden they get hemibulistic on the side in the OR. There are cases of subthalamotomy induced for Parkinson's disease. Subthalamotomy induced hemibulistic movements as well. So here's another old video I got from Dr. Swanson's library. I don't know who the examining physician is. Eric, do you know who the examining physician is?
No.
Alan? Do you know who that is? No, I don't either. So Phil knows. He told me once. I blank, and I don't know what the examining physician is. But that's hemibulismus on the left side, which has now evolved into hemichorea, presumably after a subthalamic nucleus infarct. I have another video of another patient I saw at Harborview about 10 years ago with John Zaraski. I don't know if you guys remember. He was one of our residents, graduated like 10, 12 years ago, and but this was more dramatic, so I chose this one to show. So tics are suppressible movements. That's how you define tics, with this urge to want to do it, and then you do it, but you can suppress it if you really want to for at least a time, and then it comes back with a vengeance. So they can be purposeful or they can be purposeless movements. They can be simple or complex tics. They can be motor vocal tics. You can categorize them based on those basically four things. And they can involve really any body part. And as I said, there's this rebound effect and this urge to want to do it after a period of suppression. So there are a lot of comorbid conditions which I have not listed here, but mood disorders and OCD traits are very common. They're the hallmark of having Tourette syndrome. It's very unusual not to see at least one of these things in a patient with either Tourette syndrome or with adult onset tic disorder. So Sam Zinner at Children's Hospital has given us talks on Tourette syndrome, and we had last year Elida Griffith giving us a talk at Grand Rounds almost a year ago this time, so I won't dwell on that too much, just going through some of the tick categories before I show you those two videos. So a simple motor tick would be a brief jerk of a body part. The complex motor tick can be a dystonic tick, or it can be even showing the finger to somebody. It would be, a series of repetitive movements or something like that. And a simple vocal tick would be just a grunt or a throat clearing sound. And a complex vocal tick can be any combination of words, even swear words, and that's called coprolalia. This is a let me show you this one. You've seen American Idol.
Everything's kind of blended into one, and I find myself sometimes I have to do things, but most of the time it's like can't control it.
It's like you told me up there, it's like a hiccup.
Yeah.
It's like having hiccups.
Yeah.
And so how has the experience of American Idol contributed to maybe you dealing with this or being of service to others with this similar condition?
Wow. Being on the show and being on Idol is a whole other
So he's
level
able to
of
completely suppress these movements when he sings, but right after he does that, he comes out for an interview, then he starts having these movements. So Elida Griffith showed a different clip of him as well. James Durbin, I think, is his name. So, and so this is a patient that John Oakley videotaped with me 8 years ago. He has very violent tics. We have had patients. Mike Kim has a patient with a very violent dystonic tick of the neck, who has had severe neck disease, early arthritis, and if I remember, he had to have surgery because he had severe disc protrusion, if I remember correctly. This gentleman had a stroke a year or two ago. He had a stroke because his tics were so violent that he actually dissected one of his vessels in the neck, and he ended up having a carotid dissection, which caused a minor MCA stroke. He is now weak on one side. This is before the stroke, many years ago. I still see him. So stuttering is also common in Tourette syndrome, among many other conditions that they have. So.
But then there are times when I'm excited doing something, whether it's riding motorbikes or...
He was a patient of Dr. Alex Spence, which I inherited from Dr. Spence.
I'm focused, so there's two kinds of...
So I'm going to go to treatment, and so normally we use clonidine in the adult population. I know that at Children's Hospital you guys use guanfacine, right? At the Children's, I don't know what the dose for that is, but I've never used that drug. And because it's a mild, generally well accepted drug, it causes some hypotension, some tiredness. So we normally start with that. We ramp up the dose to like 0.2 milligrams twice daily for a total of 0.4 daily. And then we use gradations of neuroleptic from low potencies to higher potencies. And there are people who actually use tetrabenazine as first, second, or third line drug in tic disorder. It's not uncommon for some countries, let's say even Canada, for tetrabenazine to be used as first line drug at low doses to suppress tics both in children and in adults. Benzodiazepines, I use them for tics as well, and there are people who actually have used medical marijuana. People have used Marinol. I have people on anticonvulsants as well. Keppra, for example. So there are a lot of other drugs that one can use to try to suppress tics. I have one girl who is on topiramate, and she was on it for headaches. She has fairly severe tic disorder with a lot of psychiatric issues, but she's on low-dose Topamax, and she's done well. Dr. Alan Truppen has had a lot of experience in using centrally acting cholinesterase inhibitors in treating tics in children, and he has told us about that. I've never used Aricept or any of those drugs for tics. Are you still using them, Alan, for tics in children?
Fewer children now, for other reasons, but it worked very well.
Mm-hmm. So what dose did you? What dose did you push the Aricept? Mm-hmm.
But I would start them off at 2.5 milligrams after a big breakfast.
Mm-hmm.
You know, mothers love to give kids breakfast, and that really dampens the side effects, the GI side effects.
Mm-hmm.
And then I would sneak it up, and I've gotten to 12.5 milligrams
Okay.
in what is basically a young adult. And it's very definitely body weight driven.
Mm-hmm.
I've only had one out of that group who had any
GI side effects.
from it. And I had one kid who was restless, and so I shifted from after the morning meal to, I'm sorry, who was sleepy, and I shifted to after the dinner meal. And it's long enough acting that he's still got good suppression.
Thank you. So Dr. Trubin was telling us about his experience using donepezil, Aricept, and he starts low and he moves the dose up to 12.5 milligrams daily in some kids with Tourette syndrome. So moving on to other terms we use for Parkinson's disease, bradykinesia, akinesia, and freezing. So bradykinesia basically means slowness of movement, and your movements are grossly slow and your finger movements are kind of small. Normally we test bradykinesia using the motor UPDRS, the Unified Parkinson's Rating Scale that we normally use for our studies. And the way we test them is finger tapping, hand opening, closing, forearm pronation, supination, foot tapping, and heel tapping. Now we have five different limb movements where we measure limb bradykinesia, and then you also rate global bradykinesia based on that scale. We sometimes do that regularly in clinics. So Sindhu and Daniel are very good at doing that every visit. I'm not as good as doing that every visit, but you will see that in the clinic notes written by them here and at the VA. Akinesia means absence of movement. It's just an extension of bradykinesia, but you will see that term being synonymously used as bradykinesia in the European and Japanese literature. So usually what they mean in those papers is the same thing as bradykinesia. So freezing is a very specific gait phenomenon. It has to do with stoppage of gait when the patient is either initiating gait or getting near a target, or when he wants to turn, or even something in a distance can kind of cause freezing right here. The most common ones are when they're turning, going through a doorway, when they get to a chair they want to sit down, or when they want to start getting going. So here's an example of bradykinesia in a patient with Parkinson's disease. It's kind of a brief video of just what slowness would look like. And here's an example of freezing. I don't know this patient. I just got this from the internet. But this is what freezing would look like. This is textbook classic freezing, and then they get going. Sometimes they do better with a visual cue. We have this thing called the U-step walker with a laser beam. You've seen it out in the hallway, and we sometimes use it for patients with episodes of freezing with Parkinson's disease. It's basically a walker that when you brake, it goes. When you let go of the brake, it stops. And there's this laser beam at the bottom that allows the patient to have a visual cue to step over that laser beam to overcome freezing. And it's very effective. So if you have, it's about $800, and Medicare does cover it. So we've used it in some of our patients with Parkinson's disease. He's one of our first DBS cases ever. And he's had Parkinson's disease for I think 25 years now. So I just wanted to show at least one comprehensive Parkinson's video from beginning to the end, where you see like the tremor, where you see the reduced facial expression and the paucity of blinking, and then he goes on to have some dyskinesia, and actually dyskinetic, he had both choreatic and dystonic dyskinesia later on when he's on. So I think he may have been our first ever DBS case in 1999 or 2000 for Parkinson's disease. Before that we were just doing essential tremor, deep brain stimulation. Let me move the video. So now he's on. He's well medicated. You can see now he has chorea and old dystonia. So he doesn't have the tremor anymore, but he's got some dystonic posturing of his ankles, of his feet, and he's got that truncal choreatic dyskinesia. One of the ways we check for chorea and dyskinesia based on the scale that was devised by Chris Getz in Chicago is that we have people put on a jacket, button it, and then take it off, and then put a glass, to their mouth, put it on the table, and things like that. So this is what chorea would look like. And for all I know, even Huntington's can look like this. This dyskinesia I showed you in that other guy who had tardive dyskinesia, to me was indistinguishable from Huntington's disease. And you do see Huntington patients who have a combination of both chorea and dystonia. And in his case, it's just Parkinson's disease with levodopa-induced dyskinesia. So you see that dystonic posturing of the left lower extremity. So he's got a bent knee and he's got ankle inversion and some plantar flexion, and that's. And going on to them. So dyskinesia is this sort of non-specific term. This means abnormal. Kinesis means movement. So it's just basically abnormal movement. But over the last 4 decades, it has evolved to mean something more specific. So it usually means drug-induced bad movement. Either it's levodopa-induced dyskinesia in the setting of Parkinson's disease, or dyskinesia in the setting of long-term neuroleptic use. So the first use of this tardive syndrome was in the early 70s by Dr. Rajput, actually, in Saskatchewan, and it has sort of taken off, and people use it to describe tardive syndromes after neuroleptic use. So you can have tardive dyskinesia that's dystonic or choreatic or combination of various movements. And in Parkinson's disease, usually drug-induced dyskinesia due to Sinemet tends to be more in the form of chorea rather than dystonia. But in the case of this gentleman I showed you, it was kind of a combination of both. He didn't have much dystonia off medication. Usually when you see dystonia in patients with Parkinson's disease, that tends to be an off-period phenomenon as opposed to like a peak dose, well-medicated kind of phenomenon. So here are very brief, I don't know where the cursor is here, very brief videos of a few patients with orobuccolingual dyskinesia. So that's basically lip puckering, sort of more choreatic dyskinesia involving the lower face. Now she's a bit more dystonic. She's got some co-contracting muscles and some sustained, almost like Mesh syndrome, except she doesn't have that much blepharospasm. She does blink. So one of the things you always want to ask is whether they have malfitting dentures. So another case, orobuccolingual. Because if they're edentulous, their dentures don't fit, they sometimes have these movements. And the treatment is again tough. You have to prevent this from happening. You stop the offending drug. Usually drugs like Artane or Cogentin help the dystonic part. They don't make the choreatic part of tardive dyskinesia a whole lot better. We do use quetiapine. We actually did an open label study of clozapine in severe dystonia. Some of them actually were tardive patients, if I remember, at the NIH when I was there. So there are cases of neuroleptics actually helping tardive dyskinesia. Now there are people who have tardive dyskinesia that becomes worse after they stop the neuroleptic, they go back on it, it gets better, but it's probably best not to use that at high doses to treat the dyskinesia. So benzodiazepines are helpful. Monoamine depleters like tetrabenazine, as I said, are helpful. In that gentleman I showed you, I'm just starting to actually get tetrabenazine for him because it would be an off-label use. It's FDA approved only for Huntington's disease, but about half the prescriptions nowadays written for it apparently are for other reasons. So treatment of levodopa-induced dyskinesia, I would probably include that as part of the Parkinson's talk later. But again, the key thing is to try to reduce the Sinemet, reduce the levodopa, and compensate for it by doing something else. Usually it's by adding a dopamine agonist, which tends to be less dyskinesogenic. You can divide up the doses more evenly throughout the day with fewer peaks and troughs so that you get less dyskinesias at peak and so on. But that I'll save the rest of it for a more extensive Parkinson's talk. Akathisia is basically motor restlessness, usually brought on by neuroleptics, which are dopamine antagonists, and inability to remain seated, shifting weights and pacing and rocking of the trunk are the characteristic features of akathisia. It can be acute right after your first dose of Haldol or tardive after being on it for many weeks to months. And then you have to stop the offending drug. That is usually the treatment for it. So restless legs is this urge to want to move your feet to alleviate this bad feeling you have in your feet. So again, it tends to be worse in the evening. It kind of builds up as the day goes on. So primary RLS is when you have a normal sensory exam with no neuropathy. Secondary RLS is when you actually have distal neuropathy, and this kind of RLS tends to respond less well to dopaminergic therapy. You got to use gabapentin and drugs like that for it. Again, it can actually be total body restless legs. It can involve the upper limbs, especially if it's in the setting of severe iron deficiency and so on. So again, you always want to ask about sleep apnea, iron deficiency, and so on, and check their ferritin level before you put them on any treatment. But if they have those things, you want to treat those. If you don't treat the iron deficiency, it's very hard to treat the restless legs. So usually we use dopamine agonists. The Nupro patch has just come out again as after 4 years of sort of dormancy. That's the new addition to RLS drug treatments that we have. And we also use carbidopa, levodopa, gabapentin, especially for secondary RLS, and benzodiazepines. And opiates tend to be fourth or fifth line drug, but we used to use them as second or third line drug when I was a resident, actually. So hyperekplexia is this very bad stall response to a sudden stimulus. So usually you see it in the setting of sort of people who have had anxiety attacks, PTSD folks. They tend to be startled. But if you're going to look at genetics, glycine receptor gene mutations in French-Canadian descent, the jumping Frenchmen of Maine, you've heard of them, with the glycine receptor abnormality, are the textbook classic ones. I saw this man at Harborview many years ago who had bifrontal and bitemporal injury, and he had encephalomalacia, and he was very hyperekplexic. He used to startle. So sometimes you do it by, startling them by clapping behind the ears. But in his case, this non-suppressible tap over the nose, you see that in hyperekplectic patients. So it's an old video. So I only have 2 more slides on psychogenicity, and that by itself is a separate talk. I gave a talk on this last year at one of our noon conference on Wednesdays. So I have a lot of videos. I just selected a whole bunch of very small clips of 2 or 3 patients to show, but I can always talk more about this. This is a very challenging area of our movement disorders, and we always try to run away or shy away from these cases, but they never go away and they keep coming back. At least that's what our guess is as to psychogenicity. So I saw a lady with Maxwell-Moy about 3 weeks ago at the VA who we thought was psychogenic based on her gait, and she had this extensive video clips of herself that she had sent us. When we examined her, she had very brisk reflexes, and she had increased tone, and she had sustained clonus at one of the ankles. It was very strange. So you can get psychogenicity on top of what you find to be organic, real findings on examination. It turns out she had neck fusion from a severe neck injury like in the early 1990s, and you never know to what degree what is what. So, but here are some of the things on history that you want to ask about. So you want to see if the onset was abrupt. That usually is a clue. A paroxysmal movement disorder when it comes and goes, and inconsistency of symptoms over time. This is a key thing. When they do something for you as you're not looking at them, and then all of a sudden they can't do it, when you ask them to do it. Usually past psychiatric history, healthcare affiliation. My time is up. Presence of secondary gain, multiple somatizations. Somebody has irritable bowel syndrome and fibromyalgia and chronic fatigue syndrome. All of those things are basically a clue. And obviously pending litigation, you see that in many of our patients after injuries. The clues on examination are that they decrease with distraction. Normally we have them do complex motor tasks in a different body part, and then it makes the movement disorder generating other body part kind of not do it anymore, or dampen that movement quite a bit, or it becomes a lot less rhythmic. Deliberate slowness of movements and inconsistent features from in terms of frequency and distribution for what you would see in an organic version of that disorder, and disproportionate disability to what you see on examination, give way weakness and some non-physiologic sensory findings like splitting the tuning fork right at the middle of the forehead, or spinous process in the middle of your spine, or very unusual sensory disturbances, or you tap them on the knee and then all of a sudden they jump off the table with delayed response or some things like that. So I'm going to show you a few videos. I don't know how many I have, 2 or 3, but this is a patient I saw many years ago. She had perfectly normal way of handling her purse, putting her glasses on, things like that, but when I asked her to do finger to nose test, she's extremely deliberately slow, and when she bypasses her face. Let's see, this is a lady who has this is a young woman in her 20s who has had serious heart problems. She had tetralogy of Fallot when she was a kid, and she had cyanosis, and she had heart surgery and all that stuff. So she came in with a sudden onset of this thing. So we wanted to, and she's got a pacemaker, so we can't do an MRI on her. I thought she had a subthalamic nucleus infarct, but why is it that her right leg is not moving at all, and her CT was normal? Then again, you don't see ST and strokes on CT scan. But it was quite variable from moment to moment, and there was days when it was totally gone. Her father said days when it was quite violent, and I'm trying to see if I can actually distract the movement by having do other stuff in a different body part. Let's see if it works.
Slower, 1 per second. Big movements.
So you're trying to see if you can actually cause entraining of that other movements when she does movement with a different body part. In her case, right now, she's doing a very good job keeping the rhythm going.
Arm too much. Just your left hand open and close your hand into a fist. Okay. And then put
So there is a little bit of a fast.
Both of them if you can. With the left hand, do the flipping back and forth. A little faster. A little faster.
Pretty good, Ali.
Okay, and now with the right hand. See if you can. Sure. Yeah, we'll wait.
So the arm movement looks a little different. I mean, it's like this, now it's kind of like that. So there is some discrepancy from one moment in time to another. I don't know if I did that with her. I usually have them do this sequential finger tapping where I have them tap 1, 3, 2, 4 with the thumb touching first the index, then the ring finger, then the middle finger, then the pinky in sequence to see if you can actually distract movements in a different body part.
Okay. Now, bring your hands a little closer to your mouth, like this. Not too close so you don't hit yourself. Let's just see what happens to your right hand when you do that. And Alexa, do you want to do the finger to nose test with her?
Sure.
Okay.
Left hand first.
You remember Alexa? I forget where she ended up going to. I think North Carolina somewhere.
Okay, very good. Okay. So we might try to get a sample of your handwriting and get it captured.
Let's see if I can. So she brings the pen down and writes quite well.
It briefly and shake it off, and then go back to the paper again. Okay. All right. Can you draw a spiral?
From inside out or
From
outside?
inside out. Yeah, inside out. See if you can keep the pen down for the entire drawing of a good spiral with several circles in the spiral. Keep going.
Okay.
So you have to let go after the third or fourth line there. Okay. So why don't you grab a couple of cups from, let's say, make the cup just 1/10 full.
Should I do like everything with my right hand?
No, you can use your left hand, water. Okay, and then
So
vice
she can
versa.
pour water at the moment when she has to.
Take your time.
And if I remember, she
So
got
can you
better.
Can you eat soup with your right hand? Can you bring a spoon to your mouth?
So she holds on enough to pour the water back into it.
Okay, pour it back, right to left.
And she goes like this and keeps the cup going. So Yeah, so examining psychogenic patients, the key thing is document exactly what you see.
have a comb or brush in your
And why?
purse?
Because it'll come back to haunt you if you don't document exactly what you see in
That's
details.
fine.
So when I did this, she did this, or he did this, and you know the kind of things that made you think there's a psychogenic component to it. You have to document it very well,
In the hallway.
because then you look back at your notes and you can't remember what you were thinking that day, and why you were thinking what you were thinking.
So how about if you go all the way to the eye chart at the back of the hallway and come back? And see if you can drop your arm to your side. I know you don't like that, but... And walk back towards me. Yeah, towards the eye chart. The chart. Arm down to your side, yeah, just walk quick.
And see if I can do it backwards and
Okay,
distract
stop
you.
right there and turn around and face me and do the sobriety walk, heel to shin, like a tightrope walk. There you go.
So I have one more video. I don't know if you guys want to stay here to watch
Can you
this.
say the months of the year, if you don't mind? Can you say
And
the
another
months of the year
psychogenic patient.
beginning in January?
January, February, March, April, May, June, and July, August, September.
I don't know how long this is.
86,
So the movement's kind of.
79,
He's doing seven. He's doing serial 7 subtractions.
85, 78, 70.
With your right hand, raise your right hand in the air as if you were to take it. You can look at me and look at the camera if you want. And I'm going to have you do just finger tapping, simple finger tapping.
I'm just having him do
Do
that.
simple finger tapping. Let me see you do that. Just tap your index finger to your thumb like that. Can you do that? Keep doing that.
So the leg movements go away. I don't know whether he's tired or not, but
Okay. You're actually tapping your ring finger to your thumb right now.
okay. I was going to stop right there. Do you have any questions? 10 after 6. I should probably minimize this so I can. So there are no questions. Thank you.